our speakers for today. This month, our Research in Progress presentation is by the Nebraska Public Health Practice-Based Research Network, and they're going to be talking a little bit about their latest project, which is the DAX project, the Delivering Cost Study project, and they're measuring the cost of implementing QI initiatives and examining variation in cost of QI implementation among local health departments in Nebraska. So today, Ong Nguyen and Janelle Jacobson will be presenting, and the co-PIs are also Dr. Li Wu Chen and Dr. David Palm. So without any further ado, Janelle?
Okay, thank you so much, and I should be able to share or advance the slides, and I can.
That's correct. There you are.
Okay, so like Lizeth mentioned, we are largely concerned with measuring the cost of implementing QI initiatives and examining variation in costs of QI implementation among local health departments in Nebraska. So quality improvement, regardless of where local health departments stand on accreditation, is an essential task for all local health departments. And currently there is a need to measure the value of delivering public health services across the nation. Also, budget constraints in local health departments has further highlighted the need to measure the return on investment of public health services. We've found that they found that barriers to QI include lack of funding, program requirements, a lack of incentives for implementation, lack of leadership, and a lack of additional technical assistance. But QI initiatives could have the great potential to enhance the value of public health services. But there is a current gap in the research on how QI has increased the value of public health services and the costs required to implement the QI initiative. And this DAX grant has been funded by the Robert Wood Johnson Foundation. Previous research that has been conducted by the Nebraska PBRN has found that 83% of the local health departments in Nebraska have started some QI initiatives. And we found that simple QI tools, such as the Plan, Do, Study, Act, or the PDSA approach, have been adaptive and found to be effective in the Nebraska local health department. And challenges that they have found in implementing QI include there's an information gap regarding QI concepts and methodologies. There's an agency culture that does not necessarily accommodate quality improvement, and a lack of capacity and resources within local health departments. But local health department leaders in Nebraska are committed to adopting QI, and they have an interest in applying for national accreditation, and that has driven them to expand QI initiatives. So the significance of our study is that there appears to be a gap in the research about how to measure the value in the cost of quality improvement initiatives in local health departments. And Nebraska does provide an ideal setting to study the cost of implementing quality improvement in a regionalized context. And we have 21 local health departments. That includes 17 regional local health departments and 4 single county health departments that cover Nebraska's 93 counties. We are hoping to gain a better understanding of the costs associated with implementing quality improvement, and this will enable local health departments to better allocate and utilize their limited resources for suitable QI initiatives, and this will increase the value of public health services delivered to the populations that they serve. And the cost information on QI initiatives and various QI tools is also especially valuable to local health departments that are still in the early stages of QI development and implementation while still facing significant budget restraints. So the specific aims of this study include, number 1, to measure and estimate the costs associated with implementing various types of quality improvement initiatives in local health departments in Nebraska, to examine the variation in cost of QI implementation among different local health department settings, and to engage the Nebraska Public Health Practice-Based Research Network and participating local health departments in translating research results into a practice setting and in disseminating these results back to the local health departments in Nebraska and across other states. So our research methodology first consisted of selecting 4 local health department sites in Nebraska and also identifying the local health department's quality improvement initiatives for cost measurement and also completing cost estimation of these QI initiatives. So for the selection of the 4 local health department sites, we picked 4 local health department sites that varied in the number of counties, with Health Department 1 having the most number of counties and Health Department number 4 being a single county site. It also varies in population size as well as population density, with 3 being relatively low in population density and the 4th being relatively high in population density, and also in the geographic population density. So there were variation in the number of frontier counties as well as variation in the number of urban. This next map shows a population density map of the state of Nebraska. And so you can see in the eastern part of the state, we have a large number of counties that are frontier counties. And in the western part of the state, we have several urban counties and rural counties. And this geographic distribution across the state can tell us a little bit more about how quality improvement can be implemented in rural and frontier counties, as well as in urban settings. We're going to switch over to Ann Nguyen.
So as Janelle mentioned, we wanted to identify the QI projects that each of the local health departments were doing. So for our first local health department, their QI project focused on improving the financial management side. This local health department is a regional local health department. It has had a history of incurring finance charges on their credit card account. So their specific objective with the QI project was to correct the process associated with the assessment of finance charges on their credit card account. 4 local health department staff and an outside consultant was involved in the QI project. The outside consultant was a quality officer from a local hospital that provided in-kind services. The specific QI method that this local health department used, the DMAIC, which stands for Define Opportunity, Measure Performance, Analyze Opportunity, Improve Performance, and Control Performance. The DMAIC is a technique within the Six Sigma technique that focuses on continuous process improvement. DMAIC aims to reduce the variation in the process. So some of the things that this local health department did to address the issue was change the day of the week that the vouchers were sent to the fiscal agent for payment. They also sent reminders to staff to turn in their invoices or vouchers. And they gave the office manager access to the credit card account so that the manager could view and make payments before the finance charges were incurred. The local health department also developed a policy on responsible credit card use. And also staff were required to give regular status reports to the director, QI team, or fiscal agent. And also the local health department did a quarterly review of the project. For the second health department, this one was also a regional health department that served 4 counties. Their goal was to improve a health education program, specifically their Women's, Infant, and Children program. They wanted more women to initiate breastfeeding. So their specific goal was to have 85% of women who receive the WIC program benefits receive individualized breastfeeding education every WIC clinic. The staff that were involved include 4 local health department staff, including 2 registered dietitians, 1 LPN, and 1 RN. The specific QI method that they used was the PSA cycle, which stands for Plan, Do, Set. And some of the things that they did to address their issue was to have the RN coordinate the project and created a tracking tool to specifically the breastfeeding education records, to record whether breastfeeding education is given in each visit. All 4 of the staff provided breastfeeding education to program participants. And each program participant could have a maximum of 3 10-minute interactions with health educators during the course of their pregnancy. Finally, they gave each a financial incentive. For the 3rd local health department, this local health department is also a regional local health department that serves 4 counties. Their QI project was aimed at improving management and policies. And in general, they wanted to ensure that all policies were reviewed at least every 2 years and that all policies are accessible to staff. This local health department is currently in the process of accreditation. So with accreditation requires organizing documentation to measure whether or not they meet the standards or measures. So the specific objectives of this project was by 12 months after QI implementation, the local health department will increase its percentage of policies that are reviewed every 2 years to 70%. Also, by 12 months after QI implementation, the local health department will decrease its average time required for staff to locate policy by 40%. The QI staff that were involved include 4 local health department staff and a QI consultant. And the specific QI methods that this local health department employs include the PDSA cycle and also the root cause analysis. And the process that the local health department used to achieve Objective 1 was they first created a baseline data about the current policy review rate. They examined the workflow of the current review process, and then they identified the barriers to reviewing policies every 2 years. Then they conducted a root cause analysis. And for Objective 2, this local health department conducted a staff exercise where each person were to retrieve 10 policies. This was so that they would determine at baseline how long it takes to find the policies. They would then interview the staff to understand the policy retrieval process, and then they would determine potential solutions, then design and implement a new process, and then review the new process for improvement or unintended. The final health department wanted to improve their chronic disease management program, specifically their Living Well program. This program started in 2009. However, they've had issues with getting program participants to finish the program. So their specific objective was to develop structure for local health care providers, patient referral to the Living Well program, and increase the number of participants in the program. The QI staff that were involved included 2 local health department staff. One served as the coordinator for the project, and the other served as the grant management oversight of the QI project. And the QI methods that this local health department used were the fishbone diagram, which identifies multiple causes for one effect, and a process map, which maps out the process and also the relationship between each process, and also the PDSA cycle. The steps that this local health department used include contracting with the local medical society to develop a physician referral program. So the local health department worked with the medical society to contact healthcare providers about the Living Well program. They developed a provider network recruitment plan, and they educated and informed providers about the coordinator referral system through lunch and learn sessions. They conducted interviews and focus groups with providers to get feedback on the referral system, and then they evaluated the effectiveness of the QI project. The local health department also did extra media promotion, which include print, radio, and city advertisements. So for our cost estimation methods, we designed a cost and labor of quality improvement implementation survey. This survey was adapted from the Substance Abuse Services Cost Analysis Program, which collects data on indirect, direct, and non-labor costs. So the survey collects information on standardized annual economic cost information, such as QI personal compensation, including salaries and fringe benefits by job type, supplies and materials, contracted services, buildings and facilities, equipment, and other miscellaneous resources. The survey also collects time on staff time allocated to the QI activities, such as job type of the personnel, the number of personnel in each job type, the time spent by each personnel in performing each specific activity of the QI project during the length of the QI project. The survey was administered to the local health department, so it's the directors, the financial officers, and or the QI staff were completing the survey, will be completing the survey. For our cost estimation analysis, we'll first measure the quantity of each identified resource item that are utilized by the QI project. We would then determine the value of each identified resource item, which is cost per unit of resource. And then we would multiply the unit cost by quantity for each resource item, and then sum such products across all resource items, then getting a total cost of the QI project. So for example, for direct labor, the quantity of each identified resource item would be the number of hours that they spend on the QI project, and the value would be obtained by their salary and benefits. And to get that, we would get their hourly wage. We would also measure the unit cost. This would first be done by breaking down the cost into fixed costs, which are costs incurred regardless of output volume, and variable costs, which are costs incurred as output increase. We would measure the unit cost by dividing the total cost of each QI project by the change or improvement in the key respective outcome measures. So for example, for local health department 1, we would divide the total cost by the reduced percentage of credit card finance charges. For local health department 2, we would divide the total cost by the percentage increase in WIC participative breastfeeding education during every clinic. For local health department 3, we would divide the total cost by the percentage increase in policies that are reviewed every 2 years and the percentage decrease average time required to locate a policy. For local health department 4, we would divide the total cost by the increased percentage of patients who enroll in the Living Well program and the number of participants who complete the program workshops. We will also conduct a cost comparative analysis, and because each local health department has different QI projects, there's no common measure to compare it. So we'll be doing a failure modes and effects analysis, get a common parameter to compare the local health departments. The tool will analyze the processes targeted by the 4 QI projects. Firstly, each local health department team will identify and list all the steps in a process of interest prior to QI implementation. The team will also list all failure modes, which is what could go wrong, failure causes, why would the failure happen, and failure effects, which is what would be the consequence of the failure for each step of the process that was identified. The team would also assign scores from 1 to 10 on the likelihood of occurrence, likelihood of detection, and likelihood of harm for each of the identified failure modes before QI implementation and after QI implementation. And using these scores, we'll calculate a risk priority number by multiplying the 3 scores for each failure mode. So there's a RPN score for before QI implementation, post QI implementation. So using the RPN data and cost estimates of the QI projects, we'll then examine how QI costs vary by the type of process failure being targeted and how QI costs is associated with a reduction of RPN after certain QI tools are implemented. So for our current status and next steps, we've already obtained IRB approval. We've finalized our instruments, specifically our cost and labor survey and our FMEA tool. And we've already sent notification letters to all the local health departments informing them about the FMEA tool and asking them to form a team to identify a team to complete the FMEA tool. Currently, 3 out of the 4 local health departments have formed a team and have already received the FMEA tool. And after the FMEA tool has been completed by the local health departments, we will administer the cost and labor survey shortly. Thank you. Any questions?
I'd like to thank you guys have done an amazing job. You've gotten quite far in your progress already. And I see that, yes, we have some questions already. I can see that Dr. Irwin has raised his hand. Are you online, Paul? You can go ahead and just ask your question.
Yeah, I am. Thanks very much, Lizeth. Nicely done, team. Just a question to go all the way back to the beginning of your presentation. How were these 4 specific local health departments identified for participating in your project?
The 4 sites, we worked with the state health department, and they have been working with Dave Palm's office, the Office of Community and Rural Health, and they identified that these local health departments were actually already doing some kind of QI initiative, and so we contacted them directly to see what kind of quality improvement initiative they were doing and if they would be interested in participating in the study.
So were there other local health departments besides these 4 that you also contacted who were a part of your larger sample? I'm just trying to understand the decision-making processes for getting to these 4.
This is Liu Chen. As far as your question, the 4 sites were identified also based on their variation, number of counties served, service size, and also the variety. And also there's another consideration is where they are in terms of QI implementation. So we try to include some departments who are in their early stage of implementation, and also some departments who are kind of more advanced ahead of other departments in the area. And also in terms of the package of QI tools used, we also want to get some variation in that aspect on the local health. So that's
Okay,
yes.
Yeah, thanks very much. That helps.
Sure. Okay, thank you.
Very good, Lee. Well, this is Dave Palm. There were certainly other health departments under consideration, but people who had really laid it out very well in terms of how we selected them.
Thank you so much. We have a question from Margaret Knight on the chat box. She wants to know, for the 3rd health department, how did they use the root cause analysis to evaluate their policy and procedure review?
I believe they just, in creating their baseline data, they just had everybody I think they just discussed what are some of the barriers to it.
Mm-hmm.
Other than that, I'm not really sure how they did their root cause analysis.
I think they, thank you for the question. Actually, this is the information, it's part of the information we want to collect from local health departments as well. And at this point, we don't have complete details about that. But part of our data collection process is to, as Anne did her presentation earlier, that is to collect information about their original process, which is targeted by their QI project. So we are using this failure mode and effect analysis tool. So, and also, try to quantify the risk, the priority risk scores associated with failure mode of their original process. And along with that information, we will also collect more details about what they did in their QI project implementation, including, in this case, your question is about the root cause analysis. So, that's a good question, good point, and we are still collecting the information.
Excellent, thank you. Kim Guerin wants to know, she also agrees this was a great presentation. She wants to know if you compensated the local health departments for their participation in the study.
We wish we could, but no, actually, I mean, we really appreciate the collaboration of these participating local health departments. They were actually very enthusiastic about participating in this project, and they are also very eager to learn the results like us, and so we have a very good collaborating relationship with departments, and we hope this is kind of they also benefit from the study, not only us. And Dave, you may want to.
Well, actually, I also want to contribute that a lot of the local health departments have either put in their letter of intent for accreditation or they're putting together their accreditation materials. And we provide a letter basically saying, thank you so much for your participation in these research projects, and this can go towards fulfilling domain number 10 of the accreditation, adding to the research base or contributing to the research base. So we tried to provide a little mutual benefit to the local health departments, but we've had tremendous support from the local health departments.
That's an excellent voice.
Dave, you may want to comment on this question again. As well.
No, I think Janelle's point is very well taken. We've had several training sessions on quality improvement from the state level, and I think there's been a lot of interest, and it's translated into real movement toward accreditation by several departments, not everybody, by several. So we're really encouraged by that. I think this, I saw this as an opportunity to, in some ways, hone their skills and find out more about quality improvement.
Yeah, and I'd like to also add that, you know, we did have some great questions a few months ago regarding whether any PBRNs had been involved at all with that part of the accreditation process, if any local health departments had come to the PBRNs to try to fulfill that requirement 10. So it's amazing to hear that you say that, you know, this helps serve that. So that's a very, very good point. There's a question from Golsar. He wants to know, how did you decide between using DMAIC versus PDSA approaches for one versus the other local health department?
This isn't something that we decided. It's something that the local health departments decided. We were just gathering the data from them. So if they wanted to use the DMAIC approach or the PDSA approach, they chose it, not us.
Okay, thank you.
Thank you.
I see another question in the chat box from Lava. Can you explain more on distinguishing between the 3 different failure modes that you mentioned? How do you use these different categories of failures, such as do you do categorical analysis as well?
The failure modes are actually, there's not 3 different failure modes. The failure modes are identified by the local health department team. Like going through their process, they identified the things that could go wrong, and
they identify the steps in the process, and then they also identify what the failure mode is. So it's more of a descriptive. We get text, so a categorical analysis would not be possible.
so I don't know if you mean like the three different failures, like failure modes, failure causes, and failure effects. Failure modes, they would identify like what could go wrong during the process. They would list it out, and the failure causes, why did it go wrong? They would list some of the things that could cause it to cause the failure mode, and for the failure effects, what are the consequences of the failure?
Mm-hmm.
Excellent discussion. Do we have any additional questions? Okay, well, hearing none, then we'll continue to the rest of our agenda. I'd like to thank the Nebraska PBRN. They did an amazing job, and obviously there's a lot of interest in this work, so thank you for the presentation today. I think it was very, very useful.
Thank you for the opportunity. Thank you.
So let's see. Okay, so moving on to our other meeting agenda items, there are just a few things we needed to cover today that will probably be shorter than our regular meetings. We just wanted to discuss briefly where we are in the improved projects. We do have all the data now, so both Lava and Rachel are heavily involved in doing a lot of the data analysis right now. And as we mentioned earlier, we will be seeking input on those individual reports. Regarding the DAX project, we have a virtual meeting scheduled for Monday, March 3rd for the DAX team. CB, are you online? Do you want to say anything about
that? Sure. So we're still in the process of also trying to provide our own input from the National Coordinating Center with regards to the protocols and instruments that you guys have uploaded into the DAX Dropbox folder. But also please keep in mind that we're also a little over a month away from our grantee meeting at Keeneland. And so we'll also provide guidance as to what we would hope to see from the DAX, I guess, presentations. But during the virtual meeting next month, it's also another opportunity for each of the research teams to provide updates on the progress of their respective DAX projects. Keep in mind, especially for the Category 1 projects, that these will come to an end at the end of July. So we're definitely trying to at least help in any way that we can to ensure that the progress of these particular projects are moving forward well. So again, we're here. If you have any questions, we're always here ready to provide assistance as well. So I think that's about it for now, Lizette.
Okay, thank you. On to some dissemination opportunities. Of course, Frontiers is our continuously available dissemination opportunity. Want to keep encouraging everybody to submit to Frontiers. And we mentioned this on the call last month, the American Journal of Public Health Special Issue Advances in Public Health Services and Systems Research. There's a call out for papers, and that is due March 10th. I understand that I did get an email from someone regarding some issues uploading that, so I have a call out for assistance, and I'm waiting to get a response from that. So if anybody else is having problems with that, please go ahead and email the Public Health PBRN at UKY.edu address, and we will see what's going on with those submissions. But I want to still encourage everybody to please submit some abstracts for that. Our funding opportunities, the quick strikes, we are, our apologies, we are behind in our review process for that. The weather here and travel schedules have caused major delays on us getting that back to you in a timely manner, but we're getting very, very, very close. So you should have an answer hopefully next week. And then I believe our next batch is due again soon. So still opportunity to get stuff in there. And as always, or as last time, we also discussed the RWJF changes in healthcare financing and organization opportunities, and you can find those opportunities on the RWJF website. Okay, moving on to our annual PBRN grantee meeting, which the main meeting obviously is going to be held Monday, April 7th. It's an all-day meeting from 9 to 4. And then we do have another short activity on Tuesday, April 8th from 9:30 to 11 before the actual Keeneland conference begins. So I just wanted to make everyone aware of those dates. We are getting ready to send out travel logistics. It's pretty much the same as last year. The coordinating center will be able to cover the cost of travel and lodging from one recipient from each PBRN. And this will cover, obviously, the evening of Sunday the 6th so that you can be there in time for the meeting on Monday, and the 7th. And it'll cover the conference hotel, cab fares, small per diems, blah, blah, blah. We need to have the name of your designated representative by Monday, March 3rd. Now, I know a lot of you have submitted abstracts, and you actually should be hearing whether those abstracts have been accepted either by the end of this week or hopefully by the latest Monday of next week. So knowing, if you submitted an abstract, that might help you make a determination of which person you want to send as the representative from your PBRN. And of course, the networks that have current DAX awards, they're going to send a representative based, and that's just written into their budget. So we understand that, you know, some networks obviously will have more than one representative. So if you could please let us know the name of your designated traveler by Monday, March 3rd, we will greatly appreciate it, because you will be having to make flight reservations pretty soon after that. As last year, any center-funded travelers who have one or more abstracts accepted might be eligible to get support for an additional night stay, and those determinations we're not going to be able to make until we get much closer to the event based on our budget. Now, regarding Keeneland registration, this is slightly different than last year. Last year, I believe that we waived all the registration fees if you were the designated grantee or if you were presenting. This year, we're not going to be able to do that. So if you are planning to stay for the Keeneland conference, even if you are the designated PBRN traveler, you will have to pay the registration fee for the Keeneland conference. And of course, if you stay past the 8th, which you would have to pay for your hotel as well. Are there any questions to that? Okay, well, I will also be sending out this in a written form so that you'll have it in front of you and you'll be more clear on all the deadlines. For those of you who submitted all of the information when we were getting ready to prepare our summative report in December, we greatly appreciate it. I know we had a very quick turnaround of that. If you want, you can now go online and look at the however many page summative report of the Public Health PBRN program. It covers everything from the very beginning of the program up until last December. So it's a great read. You can read about all the great work that you and your colleagues have been doing, and I highly encourage you to take a look at that document. Next, I'd like to talk a little bit about the Robert Wood Johnson Foundation Culture of Health. So as many of you know, over the past year, last year the foundation celebrated their 40th anniversary. So for more than a year now, the foundation has been engaged in a strategic planning process. As a result of this process, the foundation has been working to refine a new vision for their work. And they have defined this vision as a culture of health. So this, if you read, and I encourage you to follow that link and read more about this, but this involves looking more broadly at what defines health, looking at it from a bird's eye view perspective. And so culture of health is something that you're going to be hearing over and over as from the foundation in their new messaging. So again, I encourage all of you to log on to the website, to the RWJF website if you haven't been there for a while, and please look at the President's announcements regarding this new, I wouldn't call it a new direction, but it's a new way of looking at things. And again, culture of health is how they're defining this new vision. Does anybody have any questions about that? Okay. And then lastly, I do want to discuss the social network analysis survey. I know there were a lot of questions about this I believe it was the last time we talked about it, and there were questions about maybe changing some of the way that the questions were, some of the way that participation was defined. We've had some discussions in-house about this, and since we want to be able to do a lot of comparison between the last time the survey was fielded, we can't really change a lot of the definitions. We will be able to perhaps provide more guidance on a one-on-one basis if people have some additional questions about that, but we really do need to start fielding this second survey as quickly as possible. So for those of you who have already sent me your full rosters of everybody in your network and their email address and the different agencies that you're involved with, thank you very, very much. That's very, very helpful. For those of you who have not, I will be sending reminders in the next few weeks, but I would really encourage you to get those lists to us as soon as possible. Just a heads up, for any future RFPs, we will be requiring a document with your roster indicating all of the same information that I'm asking for now. So just a heads up, if anything should come up in the future, it would be good to have that document ready to go, save you some time. And as I say, we'll be requesting that in the next week or so, so please go ahead and submit that to us now. CB, anything else that you think we should talk about?
I think that covers basically everything for now. So
Okay.
again, if they have questions, they can always email us or let us know.
Okay. One more thing I wanted to talk about. There's the NNPHI wanted us to remind folks that there's a free Academy Health webinar series. The next one is Impact 101, Best Practices for Communicating with Policymakers. This is an excellent resource. I'm going to put the link there. I just put the link in the chat box, so please follow that link. That is scheduled for Tuesday, February 25th at 2 p.m., and it should be a very, very good presentation. There is another, I have a question here. Yes, even if you don't currently have funding through the PBRN Coordinating Center, we will still cover annual meeting travel cost for one person. So yes, even you don't have to have an active grant right now, we will still cover travel for you to attend the grantee meeting. So thank you for that clarification. And there was one more thing I wanted to talk to you about involving the PRC. There is a webinar on, let me look at this, Wednesday, March 12th from 1 to 2:30 p.m. And this is regarding the 123 PAP, the DVD that increases HPV vaccine series completion among young women in rural Kentucky. That's a presentation from the PRC project that we have been talking about here before. So I will see if I can send you a link to that. Here we go. I am getting ready to put that in the chat box as well. Okay, so there's the link for that PRC webinar, which will be held March 10th. So please do participate in that. Let's see. Are there any questions? I don't see any more questions in the chat box, so we knew it was going to be short and brief today. Let me show you the schedule for next month's presentation, March 20th, and it'll be the North Carolina PBRN. So we look forward to hearing that presentation. Again, both Anna and Glenn at RWJF today, they'll be having some high-level talks there, so we look forward to hearing from them when they return for a debriefing. And if there aren't any questions, then we can finish up a little bit early. Thank you everyone for being on the call today, and thank you to the Nebraska team. It was a really great presentation.
Thanks, Liz.
Thank you.
Thank you.
Bye-bye.
Bye.